Knowing is not enough, we must apply. Willing is not enough, we must do. Well, during this time maybe we can't do enough, but we can know as much as we can and make the best of it. Good evening one and all. As per your request, today we have our favorite speaker Dr. Yapij once again with us. Last time, Dr. Yapij started with dental management of medically compromised children, and today we will be continuing with the same. Friends, before starting this webinar, that I want to share that during this critical outbreak, all our South Asian Association of Pediatric Dentistry members are standing together. They are performing their best for this time while staying at home and spreading a peaceful message all over the globe. For this purpose, SAAPD members created an impactful video from their respective home to spread the message. Staying indoors. We all wish for corona free and healthy future. Hope a powerful message is delivered from this video. Have a look of this video, please. Thank you very much for watching. Now I make Dr. Yepis to presenter. Sir,
Good.
now screen is yours.
Okay, let me see. Okay, good morning. I hope that everybody can see this, and I just want to make sure that everything is working. Dr. Kumar, can you see the main PowerPoint, the main page?
Yes, I can see your main page. Dental management of its medically compromised children, of the medically compromised children.
Okay. And Dr. Kumar, are you seeing just that, or you can also see the next slide?
Next slide also.
Okay. How about now?
Yes, it's perfect.
Okay. So welcome back. I feel very happy to be back here. I all the week always very happy to know that on Saturday I will get back and I will share, and we are all going to learn. And I really like to do this, and I hope that you and your country are doing well. Obviously, I think so. Different parts of the world, different countries are starting to move in a slow reopening after this pandemic. Um, I want to share that here in the United States is depending on the state. Each state is working in their own reopening scheduling and reopening program. But we here, I live in Indiana, which again I mentioned last time. Indiana is in the middle of the United States. Here, our state actually opened the doors, at least for dentists, to provide no emergency procedures last Monday. So we are back in business. I would say that it's a different world, um, different normal. It's not the same normal. We are doing a lot of different things in the dental office to try to make sure that it's not risky for the patients and also it's not risky for our employees. At the hospital, we continue to see only emergencies, and that probably will continue at least for a couple of weeks until the hospital really tell us exactly how we're supposed to reopen the clinic. But in my private practice, we are going back to see patients on this coming Monday. So we prepare the whole office and trying to avoid patients waiting in the waiting area. Here in America, we have what we call open bay, which is a open area with several dental chairs that usually we actually use the dental chairs in the open bay for sometimes new patient exams and recalls. And what happened is, because we need to keep the 6 feet distance, which is about 2 meters, sometimes the open bay area chairs are quite close. So we are thinking out of the box to try to find the best way and the safest way to provide care to our patients. So this is a learning experience. I have been very, um, reluctant to open the office until we have really a more clear future about this pandemic, but we need to go back to business, so we will do it in the best way that we can. So welcome back. I'm very happy to be here. I hope that I have a couple of attendees to this webinar. I know dental management of the medically compromised patient is not the most popular topic in pediatric dentistry. I can imagine if this lecture will be about zirconium crowns, of this lecture will be about how to fix cross bites, of this lecture will be about how to use glass ionomers. I will have 1,000 attendees around the world, but dental management of the medically compromised patient for sure is not one of the top topics. However, and you probably, you attended the lecture last Saturday. This is really very close to my heart, and and behind this lecture, dental management of the medically compromised patient, is the reason why I decided to apply and not just only apply, just go into medical school after I finished my dental school training. When I finished dental school, I was wrong or bad. I'm not going to really go over that, but when I was in dental school, I was very concerned that dental school, my teachers and my faculty was not really going into all the potential implications of medically compromised patients, not children in general. And I came with this idea that in order to provide better care, which again, I don't think so, the idea is a good idea, but I came with this at that time. I came with this notion that if I want to be a good dentist and if I want to have good understanding of the medically compromised patients, I will need to go to med school. And here we go. I spent 7 years in med school, and so in these days, these lectures, dental management of the medically compromised children, are really something that again is very close to my heart. I used to, before I became a pediatric dentist, I used to lecture extensively in dental management of the medically compromised patient. So I used to delete the word children and just say patient in general. And I used to lecture about adults, and you can imagine how many different things can happen in an adult, and that can really have some implications of the practice of dentistry. I just want to say a few words just to finish and to start the lecture. If you are wondering a good textbook and you really want to have a good textbook of dental management of the medically compromised children, I don't think so. We have a textbook specifically for children. In McDonald, which is the textbook that I mentioned coming from Indiana, Dentistry for the Child and Adolescent, there are, I would say probably 4 or 5 chapters about dental management of the medically compromised patients. So that could be a good resource. But also, there is the book of dental management of the medically compromised patient. It's not specifically about children, but this textbook, Dental Management of the Medically Compromised Patient, by Dr. Little, 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 and Dr. Falaise, which Dr. Falaise was my colleague at the University of Kentucky, is probably the most comprehensive book here in the United States about dental management of the medically compromised patient. We need to keep in mind that these lectures are dry, boring. I know that. I cannot, stop to saying that. But remember that this is one of the difference between, going to see a pediatric dentist or going to see a dentist with training to provide care to children, and going to see a dentist who really is not really very well educated in the treatment of children. Moms and dads, they have the full expectation that we as a providers, that we as a healthcare providers, we have a full understanding of what happened or what kind of implications we'll have when the child is having diabetes or when the child is having some congenital heart problems. This is, without any question, and I keep telling my residents here in Indiana, that the dental management of the medically compromised patient is, without any question, one of the areas that really identify the pediatric dentist. It's one of the areas that we need to be very strong, and it's one of the areas that we need continued education. It's one of the areas that we really need to prove ourselves and prove to our families that we really care and we know about this. Okay, so this is the second part. My goal is to finish. We have very interesting things to talk today, so I hope that you have a cup of coffee next to you, and you can leave the power. You can just put your computer and then just go and have breakfast and come back. And this lecture, as all the lectures that I so far presented, are going to be available for you. So the disclaimers, again, I don't have any financial conflict to disclose. I'm not receiving any honorarium for these lectures. And if you see any pictures, the majority of the pictures, I took the picture, but sometimes if I use the picture for someone else, or if I use the picture for the web, I will make sure that I let you know that. Again, I believe that the lecture that I already placed on the folder is the whole lecture. However, I changed a little bit this lecture today. So you may actually have already in your computer the whole lecture, but you will see that some slides are slightly different. And if you still want to have the new lecture, well, it's not the new lecture, but the lecture that I'm going to present today, just send me an email. And honestly, I love to get the emails. Even if you don't want the lecture, just send me an email to say hello. You cannot, and I take the time to answer all the emails. I love to know about you, a little bit about you, so I love to get an email from somebody from Portugal, or I love to get the email from attendee from Saudi Arabia, or I love to get an email from attendee from Tehran, and I love the emails. I really, it makes me feel like, yes, we are miles and miles and miles apart, but when I get these emails, it feels like you were next to me during my lecture. So make me happy. Not just only send me the email asking for the lecture, but send me an email saying hello. And if you want to tell me a little bit about, just a couple of sentences about where do you live, I love to do that. I love to read your emails, and that make me feel that we are all together. So if you have the time, do that. jfyepes1970@yahoo.com. If you want to share some, remember, we have a couple of seminars in oral radiology and oral pathology, and I want to anticipate that at this point we don't know exactly when will be the next webinar, but the next webinar we are going back to oral pathology. That's my specialty, in oral medicine and oral pathology and oral radiology. That's really my strongest area that I want to share. So we are going back to that. However, if in the meantime you have a radiograph or you have a clinical picture and you want to share the clinical picture, moving out all the potential identifiers of the patient, I will be more than happy to give you my opinion. I do that all the time, and I post this in a website named drbicuspid.com. And if you want to go to Dr. Bicuspid, you can register in Dr. Bicuspid, and then you will see that I post interesting patient in oral radiology or oral pathology every single week. Finally, you can follow me in Instagram. I know many of you are following me. Every day I have a different challenge, and I will continue to do this as long as I can. I will, every single day there is a radiograph, every single day there is a clinical picture that I want to share. And finally, I didn't say anything so far, but I have a textbook, and by no means I'm trying to promote my textbook. This is the first time that I mentioned that, but you can find the textbook. I will say the name at some point. I may will actually, because I don't want to sound that I want to promote is Atlas in oral pathology, oral diagnosis in children. Okay. So we are going to start from here. Do you remember last time we stopped exactly here? Last time we talked about congenital heart disorders, we talked about asthma, and we talked about diabetes. And we are going to start today from the thyroid gland. We have a lot of slides in front of us, so I will just make sure that you feel comfortable sitting in your house or whatever are you sitting, and just relax. And I hope that you are going to survive the lecture. I truly hope that at the end, when I say thank you for attending this lecture and have a wonderful weekend, I hope that you still there. I always, one of the issues with this technology is I feel that sometimes I'm talking by myself, and I honestly, yes, webinars are important, and webinars, we need to do this. The situation forced us to do this, but I still a fanatic of the face-to-face lectures. So I hope that at some point in life, I will have the opportunity to see you face-to-face, and I have the opportunity to go to different places to lecture. I don't want to spend the rest of my life doing webinars. I will feel like, oh my God, I'm just talking by myself in my office, and it's almost like a monologue. It's just by myself. Okay, so let's go with the thyroid gland. So the thyroid gland, my mom knows this. Remember, I keep saying my mom knows this. My mom is not a dentist. So what you want to know about the thyroid gland, how issues with the thyroid gland will affect the practice of pediatric dentistry is coming in a minute. But before that, let me grab your hand and let's walk together about some general ideas. And we did the same for heart disease, we did the same for asthma, we did the same for diabetes. So let me just tell you a few things about thyroid. So the thyroid gland secretes the T4 and T3. And as you know, if I ask you, if I look at your eyes sitting there, and if I ask you, can you explain to me what is the function of the thyroid hormones? Well, I hope that your answer is, well, it's so multi-organ that it's almost impossible to explain. That's right. Really, the thyroid hormones affect the metabolic process in the entire body. So the thyroid hormone is basically a hormone that is necessary for many, many different functions across the entire human body. It's difficult to nail down and say, you know, T4 will work in this place and that's it. They pretty much work in the whole body. So the thyroid gland is located just below the thyroid cartilage. That's the apple, Adam's apple, and you can palpate that's the thyroid cartilage, and the thyroid is just located below. Um, I always, and I do this way before I became a pediatric dentist, I decide that every time that I'm doing my extra oral exam, and when I'm looking in a child or when I'm looking in a patient, I divide, obviously you do the same. We divide the physical exam in intraoral exam and extraoral exam. And when I'm doing the extraoral exam, I always, with both hands, I palpate just before the thyroid, just below the thyroid cartilage. Honestly, if you don't feel anything, that's fine. And in fact, I don't want you to feel anything. The thyroid gland is a very slim, almost like a flat gland located below the thyroid cartilage. And if it's not oversized, or if the size is the appropriate size, you are not going to feel anything. You need to tell the patient to swallow. That will help you to see that if you have a bump or you have any nodule or you have any, a growth, if the patient swallow, when the gland is moving up and down, that actually, if you have something that will help you to identify that. I will share with you in my life, and doing medicine and dentistry and pediatric dentistry and radiology and all these things for a long time. In my life, I have about 2 or 3 patients, which is not a lot, that when I did my thyroid palpation, I felt something. I couldn't tell the patient what is that something, but 2 or 3 times I refer more than 2 or 3 times, but 2 or 3 times the patient came back to me and said, Dr. Yepes, thank you to refer me to the pediatrician, or thank you to refer me to the physician, because now I have a nodule and they are going to investigate this in a little bit more detail. So that's the palpation. A little bit about the function of the thyroid gland. The thyroid gland is not actually functioned by herself or by itself. The thyroid gland is under the direction of the pituitary gland, and the pituitary gland is under the direction of the hypothalamus. And this is a very efficient and very complicated negative and positive feedback metabolism. In other words, when T3 and T4 are low in the peripheral tissues, then TSH is high. And TSH is the thyroid stimulated hormone, which is coming from the pituitary gland. And the TSH will tell your thyroid gland to produce the hormones. And when we have a T3 and T4 pretty high, TSH will be low. Obviously, the pituitary gland, you can look at this slide. The pituitary gland is under the control of the hypothalamus with the TRH. But to make the thing simple, I'm just going to explain something from the pituitary gland below. If you think that you have hypothyroidism, imagine that you may feel tired. Well, these days of the coronavirus, we may feel that we have hypothyroidism. So if you feel that you have hypothyroidism, you are sleeping a lot and you feel tired all day, and you feel that you are gaining weight, and you feel that you don't have a lot of energy, and you feel that you don't have a lot of interests of doing a bunch of different things. So you believe that you have hypothyroidism, and then you go to see your doctor. And believe me, when I practice family medicine, and I mentioned this probably in the previous webinar, family medicine is very interesting. A lot of the patients come with the same complaint. It's just amazing. If you practice family medicine and you are, doing consult a whole day, there is no question that a good number, I don't want to tell you if half or whatever, but a good number of patients will be sitting in front of you telling you, doctor, I think so I have hypothyroidism. Is one of these things that we blame the thyroid gland for a bunch of different things. So imagine that you are feeling like that. You feel tired, you are getting weight, and you don't understand why you are getting weight, because you actually are having a very strong diet, strict diet, and so you kind of have the feeling that something is going on. So you go to see your doctor, and what happened is, when we are going to explore if you have hypothyroidism or hyperthyroidism, we usually order the thyroid hormones, more specifically T3, and I'm not going to explain. There is a reason why, not T4, and then TSH. So why we need to order both? Because what happened is the majority of patients with hypothyroidism, the problem is in the thyroid gland, and we call that primary hypothyroidism. So it's the gland, the one who is not producing enough thyroid hormone. So imagine if you feel that you kind of feel tired and you feel that you have hypothyroidism, and you go to see your doctor, and they will run some blood work. If T3 is low and TSH, the expectation is if T3 is low, TSH will be higher. And then your doctor can say, okay, it seems like you have hypothyroidism, and then you will feel very happy because finally somebody is kind of telling you that you have something that you suspect. And then basically what will happen is they will give you a prescription of thyroid hormone. So that's the negative and positive feedback. TSH low, T3 high, T3 low, TSH high. So it's a negative and positive feedback between the pituitary gland and the thyroid gland. So let me say a few words about hypothyroidism. Before I say something about this, well, I will say that in a minute because I think this is one of the slides. So I will kind of stop and I will say that when I see that on the slide. I don't want to jump ahead. So hypothyroidism is about 10 times more common in women than men. The incidence increases with age. I can tell you something. There is a lot more a lot means a lot more patients with hypothyroidism, adults, than children. So the primary hypothyroidism is probably the most common. About 95% of the time, what happened is the primary hypothyroidism. And if you want to remember, I just explained, primary hypothyroidism is the problem is in the thyroid gland. It's not the pituitary gland. So the problem is something happened with the thyroid that for some reason is not producing the amount of thyroid hormone that we needed. So about 95% of the cases are primary hypothyroidism. We also have congenital hypothyroidism, which is kids who are born without the thyroid gland. And we have a name for that, cretinism, which is about 1 in 3,500 newborns. And this is what I want to say a few minutes ago, but I will say it now. One of the first things that when we were born, or when a baby is born, one of the first things that we are going to check, or the baby is checked, is for the thyroid hormone. Because what happens is you don't want to miss a kid who is born without the thyroid gland because the treatment is available. And if that's the case, if they check the thyroid hormone in a baby who is just born and there is no thyroid hormone, and then they go and look at the thyroid and there is no thyroid, if it's not treatment, that kid will have serious, and when I say serious, underline capital letters, serious issues in all kind of different systems. So this is one of the first blood work that we have, that we humans will have in our life. As soon as we are born, they are going to check of our thyroid hormone. There is also the acquired hypothyroidism, which is also, we have a name for that, Hashimoto thyroiditis, which is an autoimmune disease, which is the most common cause of hypothyroidism after the age of 8. So Hashimoto thyroiditis is an autoimmune disease. It's an inflammatory, autoimmune inflammatory process of the gland, which unfortunately the endpoint is the partial destruction of the gland And if you don't have the gland, or you have partially gland, then you are not going to produce enough thyroid hormone. What else we want to know? There are other reasons of hypothyroidism. Not very common here in the United States, iodine deficiency. In other places of the world, iodine deficiency is one of the main reasons of hypothyroidism. And it's very interesting because if we don't have enough iodine outside the environment, as you remember for your days in dental school or your days in daycare, because these days they teach this pretty early in life, iodine deficiency, I'm sorry, the thyroid needs iodine to build the thyroid hormone. So if you don't have iodine, or for some reason there is no iodine in the environment, what will happen is your gland will start to grow almost like a hyperplasia to try to capture more iodine, and then you are going to develop a big mass in the neck. And I know it's kind of a paradox that you have a big thyroid, but you are hypothyroidism. You don't have enough thyroid hormone, and you have a huge gland. But the reason that you have a huge gland is because the gland is trying to capture more iodine. In some places of the world, iodine is a problem, or it's not really something that is rich in the environment. And the way to counterpoint that is, again, in some countries, what they do is they add iodine to the salt. In that way, if you live in an area with endemic low iodine, you can get the extra iodine in the salt that you use to cook. The destruction of the thyroid gland secondary to radiation or surgical removal, obviously, if you have cancer in the gland and they need to remove your gland, you are going to develop hypothyroidism, but this is not very common in kids. So the most common reason of hypothyroidism in children is primary hypothyroidism. It's something in the gland, and what happened is quite often we really don't know exactly what happened, but the gland is just slow in the production of the thyroid hormone. So what happened when you have hypothyroidism? So you have a generalized reduction in metabolic function that manifests as a slow physical and mental activity. So you feel all the things that I mentioned a few minutes ago. You feel tired, you are not sleeping well, you have cold intolerance. So you feel like you are cold all day long, and you feel that you cannot concentrate, you feel that you cannot learn. So it's a whole spectrum of many different things. And obviously you feel that you are doing such a strong diet or strict diet and you're still gaining weight. In very young kids, hypothyroidism could be something really, really seriously. And hypothyroidism can take you to mental delay and slow physical growth. So this is a nice chart of all the consequences of hypothyroidism. And then now you know when you have a child or you have a teenager walking in through the door of your office and the parents tell you, well, my son was diagnosed with hypothyroidism very early in life, and the physician, the pediatrician, decide to prescribe thyroid hormones since early in life. This nice chart will tell you all the different things connected with hypothyroidism. You can see from mental impairment, cold intolerance, hair loss, constipation, infertility, decreased appetite, generalized edema. So this is really a mix of different signs and symptoms from different systems. Complications of hypothyroidism, rare. The complications are more common in the adult patient. In kids are very rare, I'm sorry. Mixed edema is usually the life-threatening condition resulting from a progressive deterioration of the thyroid function. Very rare. So you can just look at this slide, mixed edema, and just remember that that's the complication of the life-threatening condition resulting from hypothyroidism, and then you delete that from your brain. I know sometimes I have attendees from different places of the world who are preparing your exams. Here in the United States, in order to practice pediatric dentistry, well, not really is mandatory, but here in the United States, we have the College of Diplomates. We have the College of Diplomates of the American Board of Pediatric Dentistry. So in the United States, we take boards of pediatric dentistry. I don't know in other countries in the world if you need to do that. I know in Saudi Arabia you need to do that, and I know in some countries you need to take these boards. But here in the States, we need to take the pediatric dentistry boards, and they are two different parts. Part one is a multiple choice exam, and part two is an oral exam. So for those of you, I don't know if I have somebody here in America watching this webinar, But if you are preparing your boards, your multiple choice section boards, I don't think so they are going to ask about mixed edema. So you can delete that from your brain. Medical conditions associated with hypothyroidism: anemia, hyponatremia, which is a low sodium, and high fat or hyperlipidemia. How is the diagnosis? The diagnosis of hypothyroidism is basically blood work. And in the blood work, checking the TSH and checking T, in the slide is T4, but it's really T3. So there is a mistake in this slide. So really the comprehensive history, well, is not always enough. I mean, I'm not sleeping well, I'm getting weight, my child seems to have lack of concentration, and that's not enough. The physician need to prescribe TSH and T3. How is the dental management? And again, this is really what makes sense for us. We are not really going to provide treatment. I mean, we are not the pediatricians who are going to prescribe the thyroid hormone. We are dentists who are going to provide care to patients with hypothyroidism. So generally speaking, patients with hypothyroidism are more sensitive to the stress, which means that this is a patient that stress can actually cause metabolic issues, and metabolic issues includes tachycardia and sweating. So generally speaking, patients with hypothyroidism, we need to be, well, we do that with all the patients. We are pediatric dentists, so we are supposed to be the kings and the queens of behavioral management. So we need to be very careful in the way that we approach kids with hypothyroidism, because they probably will be a little bit more reactive than our average patient. They are also sensitive to infection. And again, when I say sensitive to infection, this is one of the fields that is a lot of controversy. It doesn't mean, and I want to say that again, it does not mean that every patient with hypothyroidism that you see in the office, we need to prescribe antibiotics. Every time that we do an extraction, we need to prescribe antibiotics. Every time that we do a pulpotomy, we need to prescribe antibiotics. That's not true. I think so. It's case by case. I don't think that just because you have hypothyroidism and it's controlled, obviously you are taking the thyroid hormone, that doesn't mean that my treatment will be different from a patient without hypothyroidism. But I need to be more careful, and I need to be more aware that a child with hypothyroidism in treatment, I may need to be more aware in terms of if I'm going to do 2 or 3 extractions of infected teeth, regardless if I decide to prescribe antibiotic or not. At that patient, probably I will call the parents to make sure that everything is fine. I may will bring this patient a week after I do the extraction to make sure that the healing is okay. I know in some places of the world we do oral sedation, and it seems that patients with hypothyroidism, they are more sensitive to some sedatives, especially benzodiazepines, midazolam, if that's what you use, or any other benzodiazepine, Valium, or any other benzodiazepine that you use. And the oral findings, a patient with hypothyroidism, they are nothing really, is absolutely, I'm sorry, you are not just going to look at the mouth of a patient and say, wow, you have hypothyroidism because you have a big tongue. I mean, I think so big tongue or enlarged tongue can be connected with several things, and there are several syndromes, which one of the features is macroglossia. And not just because you have macroglossia, you have hypothyroidism. Again, you need to see the patient as a whole patient, not just only the mouth. But these are some of the oral findings in patients with hypothyroidism. Macroglossia, malocclusion. Imagine malocclusion, how many patients, even without having any systemic issue, they have malocclusions. They have delayed dental development to the eruption. So that's one of the things that I keep telling my residents. When I'm working with my residents, I'm pretty passionate about what they're supposed to know. And one of the things that my residents supposed to know is they're supposed to know at least 4 or 5 systemic conditions who are associated with delayed dental development and tooth eruption. So my residents, they need to know at least 5. So if you, I'm not going to tell you 5. I will tell you just right now 1, hypothyroidism. So now you need to come with 4. Imagine we pediatric dentists or dentists who like to see children, we need to be aware, because sometimes moms or dads are going to ask us, it seems like my kid, the teeth are pretty slow to come into the mouth. And obviously we tell the parents that it's a range and you don't need to worry. But sometimes, if you are 2-year-old or 24 months old and you don't have any teeth in your mouth, clearly this is a delay. So now it's when you need to start to think about, okay, I have a child with really outside the normal range. It seems like there is a true delay in the tooth eruption. What kind of, you need to think about systemic conditions who are going to um, produce delay tooth eruption. And I want to challenge yourself to remember 4 because I just told you 1. So you need to go ahead and try to remember 4. Gingival edema is also one of the features of hypothyroidism, protruding tongue and thick lips, and delay skeletal development. All these oral findings can be completely absent, 0. The patient, the oral cavity, absolutely perfect. Remember, these kids are treated. I mean, kids with hypothyroidism, they are receiving thyroid hormone. And sometimes, yes, maybe a low dose, what they're supposed to need, but still, they are getting some thyroid hormone, so you may not see all these features in one patient. Let's say a few words about hyperthyroidism. Hyperthyroidism is not as, hypothyroidism is not common, but you probably will see more patients with hypothyroidism than hyperthyroidism. So hyperthyroidism is the opposite. If hypothyroidism is a hypometabolic state, hyperthyroidism is a hypermetabolic state, and you have intolerance to heat, you are not sleeping, again, you cannot concentrate, you are losing weight. So it's completely the other side of hypothyroidism. And the reason of hyperthyroidism is an excess of the synthesis and release of the thyroid hormone from the thyroid gland. Thyroid toxicosis is a general term referring to all causes of extra thyroid hormone in the body, and that could be different reasons. You can have more thyroid hormone from having cancer in the gland or having a hyperproducing area of the gland, or you are taking more thyroid hormone that you're supposed to take. So it's a whole different reasons, but at the end you have more thyroid hormone. The clinical spectrum, the patient could be from asymptomatic, so not feeling anything, to subclinical hyperthyroidism, to the other extreme, which is a life-threatening thyroid storm. Hyperthyroidism, the most common is Graves' disease. 95% of the hyperthyroidism cases in children are Graves' disease. That's the most common form. It's an autoimmune disease, so it's also primary hyperthyroidism. It's a problem of the gland. It's almost the counterpart of Hashimoto thyroiditis. Remember, Hashimoto was hypothyroidism. Graves is hyperthyroidism. So again, if you are preparing your boards or you are preparing an exam, they may ask you, Hashimoto is which one of the following? So Hashimoto is hypothyroidism and Graves is hyperthyroidism. This is an autoimmune disease. It's more common in women than men. And if you probably remember the pictures when you were in dental school taking the lectures, patient with Graves' disease, they seems to have the big eyes, but it's not really big eyes. What happened is an extra deposit of fat in the back of the orbit, in the back of the eye cavity, and that extra fat in the back actually pushes the eyes outside, so they look like the eyes they want to come out. And as I mentioned in the previous slide, you can have hyperthyroidism because you are taking more hormone that you're supposed to take, or you have a tumor, or you have a functioning adenoma of the gland, or you have cancer. But the most common is the autoimmune. So the most common is Graves'. Hyperthyroidism complications, well, it's a big portfolio of different complications: osteoporosis, atrial fibrillations, hypertension, congestive heart failure. The diagnosis, as we mentioned with hypothyroidism, is difficult because there are nothing that really will point directly to hyperthyroidism. Maybe these are some of the potential symptoms: tachycardia, intense fatigue, inability to tolerate hot environment, and the patient seems to be very nervous, like in constant anxiety. Blood tests, the same, T3 and TSH. So you probably can imagine what happened if you have a high levels of T3, you probably are going to have low levels of TSH. 95% of the time, the problem is in the gland. 5% of the time, the problem is in the pituitary gland, which is unusual. The medical treatment, if the medical treatment for hypothyroidism is the hormone, the medical treatment for hyperthyroidism is an anti-thyroid medication. It's a medication who is going to stop or slow down the production of thyroid hormone in the gland. Metimazole is probably the one who is used more widely in this planet. I know there are new medications who are used for patients with hyperthyroidism, but metimazole is probably one of the oldest and with a good profile. It really works. In some patients, no, in kids, in adult patients, sometimes the options are radioactive iodine. If I put in your bloodstream iodine who is radioactive, that iodine will go to the thyroid gland, and that radioactivity will actually kill some of the cells who are producing thyroid hormone. That radioactive iodine is usually the treatment for patients with thyroid cancer who is causing hyperthyroidism or surgery. How about dental management? I will tell you, as a pediatric dentist, I will be more concerned. This is important, so wake up or come back to the webinar if you just left to the kitchen. I will be more concerned and I will pay a lot more attention to kids with hyperthyroidism. But again, you may never will see patients. You may will see one in your whole year, or maybe a couple of patients. Hyperthyroidism is less common than hypothyroidism. However, the complications, the dental management of the patients with thyroid problems is more complicated for patients with hyperthyroidism than with patients with hypothyroidism. So patients poorly controlled or undiagnosed, so patients that they don't know they have, but they are expressing some of the symptoms, honestly, I will probably be away from any elective procedure. So I will probably just wait until the patient is under control. And patients poorly controlled, I will avoid surgical procedures and avoid the use of epinephrine. This is one of the few times in this webinar, as well as last week's webinar, that I'm mentioning not to use epinephrine, to be careful with the use of epinephrine. Patients with normal control or patients with well control, who are taking the medication, who go to see the physician, and they are having the blood work periodically to make sure that everything is under control, that patient's really nothing, any or no additional modifications of the treatment. It's very rare to see a medical crisis of hyperthyroidism in the dental office. I'm not going to even spend some of my saliva reading that. I don't think so. You never will see a medical crisis in the dental office of a patient having a thyroid storm. However, it's in the slide. If you want to read it, that's the treatment of the medical crisis. How about the oral findings? As I mentioned, with hyperthyroidism, there's nothing really that if you look at the mouth of a child and you say, wow, that kid is having hyperthyroidism, there is nothing that really. However, there are about 4 main oral findings in patients with hyperthyroidism in kids. Premature loss of the primary teeth with early eruption of the permanent teeth. This is very interesting. In the same way that I ask you 5 medical conditions who are associated with delayed eruption, and I mentioned 1, so you need to come with 4. Here, I can ask you exactly the same question. 5 medical conditions who are associated with an early eruption, so the opposite. The teeth are coming way before they're supposed to be in the mouth. And I want you to recall 5. I'm telling you 1, hyperthyroidism. And I almost feel that I want to tell you 1 more here, hypophosphatasia. Hypophosphatasia is a condition that I lecture a lot. Here in the United States, I provide lectures about hypophosphatasia, and I'm one of the speakers from different pharmaceutical companies who are involved in hypophosphatasia. And I'm very passionate about hypophosphatasia. That's the reason that I want to mention that here. Remember, hypophosphatasia is a condition that the phosphatase, alkaline phosphatase is low, and that's because of a genetic issue. And when the alkaline phosphatase is low, then you are going to have a bunch of different problems, because alkaline phosphatase is one of the enzymes that we need for building strong bones. And believe it or not, we also need alkaline phosphatase to build cementum. And so hypophosphatasia, one of the features of hypophosphatasia is one of the features, because they are like 1,000 different features, but one of the features is early exfoliation of baby teeth. And I believe me, I see maybe 1 or 2 patients per year with a highly suspicious hypophosphatasia, and mom will bring to the office the baby tooth who just exfoliate, and when you look at that, is the whole tooth. I mean, it's not resorption. This is a kid who is only 2.5-year old or 3-year old, and then the mandibular primary incisors are out when they're supposed to be out at the age of 6.5. So for this, and I know some of the attendees to these webinars are teachers, and I love it because that's what we do for a living. And I hope that if you are a teacher, you are all the time, because that's what we're supposed to do. We are teachers. So when you are working with your students, when you are working with your residents, when you are working with your mentees, I hope that you are questioning all the time your students, because that's what we need to do. We need to question all the time, in a very collegiality, in a very nice way. But I like to do that because that's, I feel like that's my job. When I'm in the clinic and I see a patient who, or the resident or the student comes to me and say, Dr. Yepes, I have a patient that, mom just told me that the teeth seems to be erupting and exfoliating quite early. So believe me, I look at the eyes of my resident and say, okay, that's fine. I want you to tell me 5 potential medical conditions that are associated with early eruption of the permanent teeth and premature exfoliation. And hyperthyroidism is one for this question, and the other one is hypophosphatasia. And I want you to remember 3. Not too difficult. You need to remember 4 for hypothyroidism and 3 for hyperthyroid. I'm sorry. 4 for delay eruption and 3 for early eruption or premature exfoliation. Also, kids with hyperthyroidism, they have a periodontal disease, and it seems like periodontal disease appear more rapidly. I would love to have a webinar about periodontal disease. As you know, the classification of periodontal disease just changed. Well, I want to say the American Academy of Periodontology, they just changed the classification back in December 2019, I believe. And I don't want to mean that every country in the world, they follow the same, but many countries, they kind of mirror the American classification of periodontal disease. And I really, it will be a wonderful webinar to do that, to talk about the new classification, because for us pediatric dentists, there are some changes in what we used to classify of periodontal disease. Finally, moms with hyperthyroidism, one of the features of the kids, of the babies who are born, they can have a tooth way before the tooth's supposed to erupt, neonatal or natal teeth. That's also a wonderful question for your students. One of the few, and I want to say that in capital letters, and I hope that you're still in this webinar, one of the few systemic reasons for a baby to be born with a tooth is hyperthyroidism in the mom. It's one of the few. The majority of kids who are born with a neonatal or natal tooth, there is nothing. And I keep saying the same, but Dr. Kumar, one of the, you will tell me when we are coming back or whatever, but I'm just telling you ideas. I have an amazing lecture, amazing, I love it. I don't know why I didn't think about this lecture, which is about oral pathology in the baby. And it's an amazing lecture of all the potential issues that you can see in the mouth of a baby. And sometimes, sometimes not everything is so benign. And so one of the things that I cover in that lecture is neonatal and natal teeth. So Dr. Kumar, just an idea. Okay, so we finished endocrine. We are going to move to patients with renal disease, kidney disease. I hope that you're still awake, because if you are just in the mix between awake and sleepy, with the next 20 slides, you are going to fall asleep. So I'm sorry, I don't have anything else to tell you. Renal disease, yes, is one of my favorites, but it's very dense. And so if you are having some sleeping issues, I don't know if this lecture is recorded, but if you are having some sleeping issues, rather than taking hydroxyzine or taking antihistaminics or whatever, or reading before going bed or doing all different kind of strategies to go and sleep well, you can just put this lecture starting from here until I finish patients with renal disease. And I guarantee that you are going to be with deep sleep in about 5 minutes. So no more Dramamine, no more antihistaminics, no more pills. And if you are flying in a long flight and you want to fall asleep, you can put my lecture, and then you are going to sleep like a baby. Okay. So dental management of patients with with renal disease. So let's start with this. So the kidneys are kind of a quite unique organs, and they convert more than 1,700 liters of blood per day into about 1 liter of high specialized concentrated fluid that we call urine. So the kidney function, the nephron is the functional unit of the kidney. As you know, the kidney, they filter the blood in about the rate of filtration, and we are going to talk about this number later because it's important. So the rate of filtration is about 125 ml per minute, and that's what we call the glomerular filtration rate, or GFR. So in a day, about 5 liters of blood is filtered about 56 times per day. So the blood is going constantly to the kidneys and is filtered. And if I ask you, you know, this is, again, I like to use the term Dora the Exploradora. And when I say that means that you need to know that this is not rocket science. And it's funny, sometimes in dentistry, and I'm sorry to tell you this, but sometimes in dental school, we dental educators, we fail. We ask students to memorize the composition of alginate, and we spend hours trying to memorize what is in the alginate and all these things. But then when I ask my students what is the function of the kidney, they don't know. Sometimes with dentists, we need to look more at the comprehensive learning. You know, yes, we work in the mouth, but we are the physicians of the mouth. So we need to know the main kidney functions. I understand we need to know what is the alginate, and we need to know that, but honestly, sometimes we place a lot of attention to a bunch of knowledge that I don't find that important. And what is important, we don't know. And sometimes our physician colleagues, they see us as, you know, dentists, they really don't know anything but teeth. And I feel embarrassed because sometimes that could be true. So in this slide, I hope that you know the kidney function is not rocket science. The kidneys are involved in a bunch of different things. Probably one of the most well-known is the excretion of waste products of the metabolism, including medications. As you know, the kidneys are involved in the fluid and electrolyte regulation. They are involved in the pH balance, acid-base balance. And finally, the kidneys are involved in the production of hormones. And you can see the list. At least 4 hormones are produced in the kidneys: erythropoietin, which I would love to see your eyes now, Dr. Kumar, and ask you, Dr. Kumar, tell me, erythropoietin is used for what? And then you will look at my eyes like, wow, I don't know, Dr. Yepes, I don't know. And then you will start to cry, Dr. Kumar, and I will tell you, Dr. Kumar, you will need to go to the corner, and until you know where erythropoietin will work, you will come back to clinic. And I will see the tears in your eyes, Dr. Kumar. But you will remember next time that I ask you, what is the main function of erythropoietin? So erythropoietin is a hormone related with the production of red blood cells in the bone marrow. So you can have anemia if you don't have enough erythropoietin. In fact, children with some kidney problem, they can have anemia for that reason. So other hormones produced in the kidney: renin, prostaglandins, and angiotensin. Prostaglandins, they are involved in a bunch of different things, including pain, and angiotensin and renin are related with the pressure inside the blood vessels. So this webinar, obviously, we don't have the time to go and review all the different kidney disease that a child can have. Is quite complicated. So this slide is just to show you all the potential diseases that a kid with kidney disease can be affected, from urinary tract obstruction to acute nephritic syndrome and nephrotic syndrome, I'm just going to center in the next slides, because we don't have the time, in chronic kidney disease. I'm going to center in that because that's probably the one with more implications for the practice of pediatric dentistry. So I'm going to center later on in CKD, which is chronic kidney disease. So chronic kidney disease, and by the way, please listen this, chronic kidney disease, CKD, is the endpoint of a bunch of different kidney problems. In other words, chronic kidney disease itself is not a disease. This is just the endpoint of many different diseases who are going to affect the way that the kidney work. Imagine, and I want you to answer this question by yourself. What do you think happened if you have a child who enter into chronic kidney disease for X, Y, or Z reason? And remember, could be many different reasons. What will happen eventually with that child who now is having chronic kidney disease, and it seems to be getting down? Every year, the kidney seems to working worse and worse and worse. Well, I hope that you are thinking what I'm thinking. That child with chronic kidney disease, at some point, the child will need a transplant, a kidney transplant. You cannot just continue living in this planet without kidney. We need a kidney. So children with chronic kidney disease, at some point, they are going to need a transplant. So chronic kidney disease is defined as a renal injury, and the glomerular filtration rate is less than 60. Remember, the normal glomerular filtration rate is 125. So the prevalence of chronic kidney disease is about 8 per million. The prognosis for the baby, the child, or the adolescent with chronic kidney disease has improved dramatically since the 1970s, and you probably know why. Before the 1970s, many kids with chronic kidney disease will just simply die, but in these days, they survive. And the reason that kids with chronic kidney disease survive is because we have a lot of options. Dialysis, we have the kidney transplantation, and also we have the medical management. And the medical management really help to give more time to the kidney before need to be the transplantation. So this slide, you really don't need to know anything here, but remember, the chronic kidney disease is defined by the glomerular filtration rate, and I mentioned that the glomerular filtration rate normally is 125 ml per minute. So in the way that the glomerular filtration rate goes down, then you will go to a different stage of chronic kidney disease. If the glomerular filtration rate is less than 15 ml per minute, which is pretty low, that child is in kidney failure, and either they will need to plug it to a dialysis or they will need to find a kidney for him. So what is the etiology? So I mentioned before that chronic kidney disease is the end point of many different diseases that can affect the kidneys, from congenital, acquired, inherit, or metabolic renal disease. So chronic kidney disease, listen to this, chronic kidney disease is almost the same like congestive heart failure. You know, congestive heart failure is the end point of many different heart diseases. Well, chronic kidney disease is the end point of many kidney diseases. Chronic kidney disease in kids less than 5-year-old usually is because you are born with a congenital abnormality in your kidneys. And that's what we call hypoplasia, which means that your kidneys are maybe smaller, or they are normal size, but they don't do the job in the way that they're supposed to do the job. Or you are born with an obstructive nephropathy. In kids who are older than 5, the reason of chronic kidney disease is usually different. So in the kids who are older than 5, usually the reason of chronic kidney disease is an acquired disease, like glomerulonephritis, or polycystic kidney disease, which is actually an inherited disorder. So that is usually the main reasons of chronic kidney disease in kids, and the difference between less than 5 and older than 5. So just in summary, the main cause of chronic kidney disease in kids include all of the following. And so different diseases. Going back to the previous slide, I hope that the computer is working. In kids who are little ones with CKD, is usually a congenital problem. And in kids who are older than 5 is usually something that you acquire, glomerulonephritis. And this is all the list. So what happened? So my friends and my attendees to this webinar, I can imagine, you know, how disappointed you are signing for this webinar and saying, why I am doing this, why I'm torturing myself. So I will just go as quick as I can with this. So what happens if you have chronic kidney disease? So in addition to the progressive injury of the kidney, you are going to have a bunch of different things. So this is the pathogenesis. Initially, when your kidney is not working very well, you go into a phase that we call hyperfiltration. So your kidney is actually trying to filtrate, because in the way that you are losing nephrons, other nephrons are trying to increase the size to try to compensate for that. And the way that the kidney is trying to compensate is trying to hyperfiltrate. Then you are going to start to have proteins in the urine, which is obviously that's not normal. And then you are going to have hyperphosphatemia, which is not normal. You're going to have a lot of calcium phosphate in your blood vessels. And what are the clinical manifestations? Kids with chronic kidney disease, what will happen with the kid? So the clinical manifestations of chronic kidney disease are really different and depending on the underlying renal disease. Children and adolescents with CKD from chronic glomerulonephritis, they can have edema, they can have hypertension, they can have blood in the urine, and they can have proteins in the urine. And children with congenital disorders such as renal dysplasia, they can present with neonatal periods of failure to growth, polyuria, dehydration, and urinary tract infections. Now, you can tell that I'm clicking a little bit faster this slide because I don't want to lose you. I don't want to lose you. So it's fine. The last two slides, you can delete that from your brain. So let me tell you a little bit about the laboratory findings. And again, this is for the pediatric dentist or for the dentist. I'm trying to keep this as easy as possible. And I am not really going to explain this in a lot of detail, but I just want you to know, generally speaking, how are the labs of patients with CKD. So the laboratory findings include elevations in the blood urea nitrogen and serum creatinine, and also include hyperkalemia, hyponatremia, and really a disbalance of the electrolytes. Kids with chronic kidney disease, they develop anemia, and we know that because the erythropoietin, they have a high cholesterol, and the most widely used marker is the creatinine clearance. And if the creatinine number is high, that is telling you that the kidneys are not working in the correct way. What is the treatment? What do you think is the treatment for patients with chronic kidney disease for the pediatric dentist? So the treatment of kids with CKD is a multidisciplinary team. Initially, when the function is not too bad, the treatment is fluid and electrolyte management. So as you can imagine, kids with this problem, they are going to have a very strict diet when they are going to try to control the sodium and the potassium, and the kid probably is going to have some water restrictions or liquid restrictions. So they may actually need to drink less liquids, and they may actually need to drink less sodium. So initially, when you have chronic kidney problems, the physicians will try to have a diet and make sure that you are not really forcing the system to have an overload of water, overload of sodium, overload of potassium. So they will try to keep your potassium balance in the perfect way. They are going to try to avoid acidosis, which, remember, the kidneys are involved in keeping the pH in 7.4. So if you have chronic kidney disease, your kidneys maybe are not going to be able to keep the pH in the normal level. So a lot of the kids with chronic kidney disease, they develop acidosis, which means that the blood pH will go below 7.4, which is bad. And so quite often, one of the medications that you will see in kids with chronic kidney problems is bicarbonate, and that's to try to avoid the acidosis. Kids will go in a very strict nutrition diet, and some of the kids will need growth hormone. As you know, the kidneys are also involved in the growth, so some of these kids will need something to help the kid to grow in a normal way. The next two slides is probably one of the few things that you need to know about chronic kidney disease and the practice of pediatric dentistry. Well, not one of the few, because I will tell you a few more in a minute, but I just want to introduce this term to you because this is one of the potential complications of patients with chronic kidney disease, and this is renal osteodystrophy. And renal osteodystrophy, or RO, is used to indicate a spectrum of bone disorders that we can see in patients with chronic kidney disease. And what happened is the most common condition seen in children with renal osteodystrophy is a high turnover bone disease, and that's caused by secondary hyperparathyroidism, which honestly, I am not going to explain why children with chronic kidney disease, they have hyperparathyroidism. I'm not going to explain. Just enough to say that kids with chronic kidney disease, they have hyperparathyroidism, and the consequence of that is a high bone turnover, and the endpoint of that is renal osteodystrophy. So this is the pathophysiology of renal osteodystrophy, which I'm not going to read it. I'm just going to kind of go directly into the yellow endpoint. Children with chronic kidney disease, they have an increased bone resorption. In a simple way, Dora the Exploradora cannot be more simple. Children with chronic kidney disease, they develop osteoporosis, period. That's it. And I will show you in a minute that the osteoporosis may have some implications in the oral cavity. So renal osteodystrophy will have clinical manifestations, muscle weakness, bone pain, and fractures with minor trauma. The treatment of renal osteodystrophy is administration of vitamin D. And I will show you one case who was published a few years ago, and there are several cases of this published in children with renal osteodystrophy. Remember, renal osteodystrophy is one of the components of the spectrum of chronic kidney disease. So this is a report, and I just brought one, but there are millions of reports. This is an 11-year-old male coming to the dental office with chief complaint of loss of the front teeth. So early exfoliation of teeth. Remember, we mentioned hyperthyroidism, hypophosphatasia, and disease number 3, renal osteodystrophy. Renal osteodystrophy will cause early exfoliation of teeth. This patient was significant medical history for chronic kidney disease and hypertension, and the patient was in hemodialysis for 6 months before coming to the dental office. The patient was taking potassium and many different medications. And this is the kid. And you can see that not just only he was having bone issues, long bone issues, but also when you look at the panoramic film that you can see over the right side, you see a loss of the normal bone trabeculation, lack of the inferior cortex of the mandible, and also delay eruption of the permanent teeth and early exfoliation of the baby teeth. So renal osteodystrophy is something that I hope that you are not going to see so many patients, but that's one of the complications of chronic kidney disease. Okay, so what is the treatment? What else is in the treatment of patients with chronic kidney disease? Well, physicians will need to take care of the anemia. They also, kids with CKD, they also develop hypertension. And sometimes, and this is important for us, listen, Dr. Kumar, don't get any sleeping now. Children with chronic kidney disease, they may need an adjustment of the medication dose because many medications are excreted by the kidneys. If you have a patient with chronic kidney disease, you may actually need to if you need to prescribe acetaminophen or if you need to prescribe ibuprofen, you will need to do an adjustment of the medication dose because that excretion of the medication may be affected. At the end, if you have chronic kidney disease and it's a progressive condition, so it will continue going worse and worse and worse, at some point you are going to have something that we call end-stage renal disease. And if we have a child with end-stage renal disease, this is a child who needs to go into hemodialysis or peritoneal dialysis, or they need to find a kidney. You cannot be alive if you continue with end-stage renal disease for a long time. So end-stage renal disease is the end point of renal dysfunction. At this point, they need to transplant the kidney. there is not enough to continue doing all these different things. You know, the kidney will fail and somebody need to give you a new kidney. Interesting enough, in the United States, 75% of children with end-stage renal disease, they need to go into dialysis before the transplant can be performed. And this number, 75%, is probably the same number in many countries in the world, because what happened is the kidney is not available, the transplantation is not available immediately. So some of these kids will need to go into dialysis before they can receive the transplant. Dialysis is the last stage of end-stage renal disease, and the selection of the dialysis modality must be individualized. Now, I put this slide when I was preparing this seminar. In the United States, about 2/3 of kids with end-stage renal disease, they will go into peritoneal dialysis. So 66% of the kids will go into peritoneal dialysis, and about 33% of the kids will go into hemodialysis. You maybe are listening to this webinar and kind of asking yourself, what do you mean peritoneal dialysis? What do you mean with hemodialysis? Well, it's different. Peritoneal dialysis and hemodialysis are two different procedures. At the end, they are trying to clean your blood, that's right, but the way that the procedure is performing is different. Age is one of the important factors. Usually for young kids that they need dialysis, they probably will go into peritoneal dialysis when they are older, younger than 5. And when the kid is older than 5, probably will go into hemodialysis. Remember, these kids are waiting for the kidney transplant. So peritoneal dialysis is performed at home. So I see patients in my office and at the hospital who are having peritoneal dialysis. And one of the reasons that peritoneal dialysis is preferred for young kids is because it's a little bit easier to do it. You just do that at home. It's a continuous cycle daily, and it's performed usually at night. And without going into too many details, basically they are going to block or connect some pipes to your abdomen, and basically we are going to use the peritoneal membrane as the membrane to filter your blood, and that is actually done at home. Advantage and disadvantage, you can look at that. You know, it's easy to perform peritoneal dialysis. However, unfortunately, peritoneal dialysis is less effective than hemodialysis. One more thing important for us as a pediatric dentist, peritoneal dialysis does not require anticoagulation. Hemodialysis is the one that you probably know. Hemodialysis is the one that is performed at the hospital about 3 times per week, 4 hours per session. You need to be plugged with this machine who is going to take all your blood and is going to filter your blood and put it back in your system. Hemodialysis is probably more effective than peritoneal dialysis. However, as you know, during the time of the hemodialysis, the patient needs to be anticoagulated. And usually the medication who use for anticoagulation is heparin. So it's not a good idea to provide any dental care after the hemodialysis, because the patient will still maybe anticoagulated. And remember, these kids are waiting for the transplant. So complications, they are probably more complications with hemodialysis than peritoneal dialysis. The complications are infection, infection of the place that is connected to the catheter, bleeding could be a problem, anemia could be a problem, risk of hepatitis B, hepatitis C, and HIV infection. Well, in these days, it's not too common because they make sure that they clean the hemodialysis machine so you don't get infected. But obviously, 20 years ago, you can get infected with hepatitis C for dialysis. How about the renal transplant? So, as you know, the endpoint for all these kids who are having all these issues, you know, the ideal treatment is the kidney transplantation. The 5-year survival rate for kids with a kidney transplant is higher than kids who are in dialysis. Obviously, we prefer the transplantation than the dialysis. However, as you know, kids with a renal transplant, they will need to be immune suppressive for a long time, and that's a potential issue. In my state, here in Indiana, the first kidney transplant was performed in 1965. In these days, since 1965, we have about 6,000 kidney transplants. So we have about 6,000 patients in the state with a new kidney. Just to give you an idea, I see about 1 patient with a kidney transplant per month. So we have a good experience working with kids with kidney transplant. So what is the dental management concerns? And again, if you are now awake again and you are back to the lecture, so this is the point that you probably need to put attention, because this is how a patient with a kidney issue is going to affect my life. And so this is probably the place that you need to put more attention rather than all the other slides that I put in the presentation. So kids with bleeding problems, that could be an issue. Impaired drug metabolism, hypertension, they can have a shunt infection. I don't think so. Hepatitis B or C will be a problem. Anemia could be an issue, and renal osteodystrophy. Remember, we talked about that early on. That's osteoporosis. So the dental management of these kids need to be for conservative care. I will have a consultation with a physician. I will avoid dental treatment in kids with chronic kidney disease who are poorly controlled. We apply the same to any other medical issue. Is okay, and we can do this, so the physician can do this. We need to do the screening for bleeding disorders before any surgery. Make sure that the bleeding time, PT or prothrombin time, and the platelet count and hemoglobin and everything is fine. We need to monitor the blood pressure. We need to do a good surgical technique. In a minute, I will tell you what are the medications that we need to avoid in patients with this. Sometimes we need to consider the reduction of the dose. We need to manage orofacial infections very aggressively in kids with kidney problems. And obviously, I work in a hospital, and sometimes patients with a severe infection who are also having kidney problems, we need to admit it to the hospital because they will maybe need IV antibiotics. How about the prescription of medications? So the prescription of medications in patients with kidney issues is something that, no question, we need to look very careful, because the renal failure substantially slows the drug biotransformation. So there are many active or toxic metabolites depending on the renal function for elimination. So we need to be careful when we are going to prescribe the medication, that this is not a medication that is going to have a lot of metabolism in the kidney, and that could be an issue for the patient. If this is a medication like acetaminophen, I'm sorry, I'm going to say Tylenol, because I know that's probably what you remember. Tylenol is mainly metabolized in the liver. So if you have a child with some kind of kidney problems, probably Tylenol will be a good prescription, because that medication will go through the liver and it's a minimal concern in patients with kidney problems. So depending on the severity of the glomerular filtration rate is maybe the problems with the medication that we are going to prescribe. This is, my friends, the teachers who are attending this webinar, the pediatric dentists who are attending this webinar. This is, I know, it's an article from 2010, so it's about 10 years old, but it's still the most important, iconic article about the prescribing medications in patients with renal failure. So this is the classical article who is going to tell me which medications are safer and which medications I need to pay more attention. So let's go, and I will not really read every single medication. This presentation, by the way, these slides are not in the presentation that I uploaded last week. So if you want to have this, you probably need to ask me. So I will make sure that I will give you this presentation. So antimicrobials or antibiotics, penicillin V or pen-VK is okay to use. Amoxicillin, you probably need to increase the dose intervals depending on the severity of the patient. Amoxicillin is a medication who is metabolized in the kidneys. So if you have a patient who is really in end-stage kidney disease, almost ready to go into the transplantation, you need to be careful when you prescribe amoxicillin. You may need to prescribe amoxicillin every 24 hours. Cephalexin, you need to increase the dose. Erythromycin is okay. Azithromycin is okay. Azithromycin is also one of my favorite medications to prescribe in patients with some kind of kidney issues. Macrolides, which is azithromycin, clarithromycin, and erythromycin, are usually okay to prescribe in patients with kidney issues. Clindamycin is okay. Avoid tetracyclines. Analgesics, acetaminophen. I mentioned before, acetaminophen is okay to use in patients in a normal intervals. Aspirin is okay if a patient with severe kidney problem, I probably will avoid. Believe it or not, ibuprofen is okay to use in patients with normal dose and intervals. If you are going to prescribe codeine, I hope that you don't prescribe a lot of codeine in kids. Is in mild kidney disease is okay, but in patients with more severe kidney damage, you probably need to change the dose. How about the local anesthetics? The majority of local anesthetics are metabolized by the liver, so lidocaine is okay. If you do oral sedations in your country, I know in some countries oral sedation is not very popular. Here in the States, we do sometimes oral sedations. So we need to try to use a short-term sedatives, and diazepam, which is okay. Triazolam is okay. How about dental management where the patient is in hemodialysis? So the recommendations are the same for a patient receiving conservative care. What else in a patient with hemodialysis? Avoid the dental treatment the day of the dialysis. Common sense. You are not going to tell a patient going to the dialysis on the same day, come to my office. And if you are one of my residents, I will ask you, give me a good reason why is not a good practice to provide dental care the same day of the dialysis. So I hope that my resident will answer, well, it's not a good practice to provide dental care the same day of the dialysis because avoid excessive bleeding. Remember, for the hemodialysis, they put the patient in anticoagulation. Patients with the shunt, which the shunt is the way that they connect the dialysis to the blood system. You know, it could be a potential infective endocarditis. So in other words, the shunt can be infected and that can cause infection of the heart. So the American Heart Association recommend that patients with vascular access or shunts, they don't need prophylaxis for dental procedures. So if you have a patient with a shunt, obviously this is a patient who is having hemodialysis or peritoneal dialysis, you don't need to prescribe antibiotics 1 hour before the dental procedure. How about the oral changes? Well, if you have a patient with anemia, you may well see the oral mucosa more pallor or more kind of a pale. For some reason, patients in renal failure, they are going to have more red-orange decoloration of the mucosa just because the carotenes are not well eliminated through the kidney. So these pigments, sometimes they accumulate in the oral mucosa. Xerostomia is one of the potential complications of renal issues. You may will have the ammonia-like breath odor, metallic taste. I have a couple of patients in my life that they have uremic stomatitis, which means when you are having issues and you cannot eliminate the urea in the correct way and that accumulates, then you can have this red burning mucosa covered by a gray exudate that may ulcerate, and we call that uremic stomatitis. You may see petechia and ecchymosis, especially patients who are in hemodialysis. And we talked before about the renal osteodystrophy, which at the end will give you almost like an osteoporosis. And these are, this is interesting. This is in the textbook of Dr. Nabil, which is oral and maxillofacial pathology, which this is the most iconic oral pathology textbook that you can have. And one of the authors is Nabil Dam, and Dr. Dam was one of my colleagues when I was at the University of Kentucky. And when they talk about renal disease, they will mention that in some patients with renal failure, they can have a growth of the palate. And that growth, the palate, I never see a patient with this in my life. I want to say that. You may, in some places of the world, you may see that. I never. But this growth, the palate, is secondary to hyperparathyroidism. I didn't want to explain what is the connection between renal failure and hyperparathyroidism, but there is a connection. And this growth of the palate has a name, is the brown tumor. And I just mentioned this because if you are a resident or a student who is planning to take your board, they may ask you about the brown tumor. So the brown tumor is a tumor who is connected with hyperparathyroidism, and hyperparathyroidism can be connected with renal failure. How about from the radiographic perspective? You are going to see some, especially in patients with severe renal failure who are either already in hemodialysis or peritoneal dialysis, so they are very close to getting to this stage. You are going to see loss of the lamina dura, and kind of the appearance of the bone is going to show you this ground glass appearance. And these are the renal osteodystrophy, which is this big cavities within the bone. And we talked about this before. So this is the management of the patient with kidney transplant. This is the patient, the child who already got the transplant. And remember, these kids are immunosuppressive medications. And the immunosuppressive medications, they increase the susceptibility for the infection. So if tomorrow or Monday, when I get back to my office, the first patient of the day is a patient who already got a new kidney a year ago, 2 years ago, whatever, it doesn't matter that. If that kid is highly likely that the kid is getting immunosuppressive medications, my main concern is the susceptibility for infection. That kids can get infected pretty easy because they are taking medications who are going to suppress your inflammatory system. So no question, I will have a consultation with the physician. I will have a frequent recall and prophylaxis. I will recommend to the patient to have daily use of mouth rinses with chlorhexidine. I will be very, educate the parents and the child to have an excellent oral hygiene and to solve and to come to the office every 6 months. I will avoid the use of NSAID. So I will avoid, this is the patient in kidney transplant. I will avoid the use of ibuprofen. I will consider antibiotic prophylaxis for invasive procedures. This is controversial. So if I'm going to pull out 5 baby teeth, I may actually prescribe antibiotics before the extraction. I will do a very nice screen for head and neck cancer. I always do that. And the last bullet point, consider the need for supplemental steroids, especially in the patients who are taking steroids. This is controversial. I published a paper a few years ago about trying to reevaluate this. As you know, is the common knowledge that when you have a patient taking steroids, if you are going to provide extensive treatment to the patient, you may need to supplement the steroids, because if you take steroids for a long time, you may actually stop to produce your own steroids, which are coming from the suprarenal gland. So there is this, and I learned this in dental school, that if I have a patient taking steroids and I am going to provide extensive dental care, I may need to prescribe an extra doses of steroids or supplement steroids. However, I published an article a few years ago. We published the article in the Journal of the American Dental Association, and we couldn't find really a good evidence-based dentistry to support the supplementation of steroids in patients who are already taking steroids. So I don't want to, in this webinar, I don't want to give you the idea that every time that you have a patient who is taking steroids, you need to supplement, you need to double the dose of steroids before doing an extensive dental procedure. I don't want to say that. I just want to say that case by case, sometimes we may need to do that. And that's the reason that we need to have a close consultation with the physician, because you don't want to go ahead in a patient with, for example, kidney transplant, who is taking a high dose of steroids for a year, and you need to pull out 5 baby teeth, and you didn't consult with the physician, and you didn't prescribe supplementary steroids. You don't want that patient to have a pretty bad reaction, because he's not going to have enough steroids to react to the infection or to the healing. So, conclusion. I know you are confused. I want to confuse you. That's part of the idea of having a seminar or a webinar on Saturdays, to make sure that I confuse your life. But I think it's enough to say that if you have a patient who is taking steroids, listen this, if you have a patient who is taking steroids, you may need to prescribe extra steroids before a dental procedure. You may need to do that, okay? So if you are in Saudi Arabia, if you are in Iran, if you are in Pakistan, if you are in Europe, if you are here in America, if you are, I don't think there's anybody in South America, but if you are in any place of the world and you have a child who is taking steroids, not just only for kidney transplantation, remember, there are a lot of different conditions that they will require daily steroids, daily dose of cortisone, or daily dose of prednisone, I will recommend you as a good pediatric dentist to do a consultation with a physician and to at least ask if the patient will need a supplemental dose of steroids. Okay? I hope that if you are, I mentioned some of the countries because when I look at the emails, when you send me emails from different places of the world, I love it. The other day, I got an email from a pediatric dentist from Pakistan. It was really so nice for me to know that there is a colleague of mine, that there is a pediatric dentist listening this webinar, connected at home or at work, I don't know where, but from country that sounds so far away from me. But it really make my day when I got that email from a dentist from Pakistan. I feel so blessed, and I feel so fortunate that thank you to Dr. Kumar and the association that they opened the doors for these seminars. Okay, we still have having things to talk.
Yeah, thank you,
So,
Dr. Epi.
okay, so let's go. I'm sorry.
No, you continue.
Okay.
You can.
So let's go with dental management of pediatric patients receiving chemotherapy, hematopoietic cell transplantation, and or radiation. So if you are thinking when this guy is going to stop to talk, I have bad news for you. I'm not going to stop to talk soon. So I will continue to torture you. Um, and if you are, I don't know, if you are in India or you are in Pakistan, I love to hear that you are still connected. So send me a text. I'm sorry, send me an email saying, I'm here and I still listen to you. Okay, so let's go with this. This is very interesting. We are going to talk about kids who are in chemotherapy. So imagine kids with acute lymphocytic leukemia, for example. Depending on your practice, if you are a pediatric dentist who is mainly working in private practice, I don't think that you are going to see a lot of kids who are getting chemotherapy. You may will see some kids who are into hematopoietic cell transplantation, or they got it before. But definitely, for some of us who are working in a hospital, we see kids with this all the time. And if you look, for example, Dr. Bicuspid that I mentioned before, the Dr. Bicuspid case for last week was a kid who was getting chemotherapy. So I see a good amount of kids who are into chemotherapy. So these are the guidelines for dental management of pediatric patients receiving chemotherapy, hematopoietic cell transplantation, and or radiation. So as you know, this is kind of the background. This is general knowledge. The most frequent documented source of sepsis in the immune-suppressed cancer patient is the mouth. So we need to be very serious here. I mean, the mouth in a kid who is getting chemotherapy or radiation therapy or hematopoietic cell transplantation, if it's a place who can make life pretty complicated, is the mouth, because that is probably the place who is going to be the source for the sepsis. So knowing that, early and definite dental intervention, including comprehensive oral hygiene, no question that decreases the risk for an oral and associated systemic infections. Now, the next statement is nice, but in real life usually never happens. So this is one of the things that, in real life, we usually don't see that. We see that in the textbooks, in the webinars, but in real life, we don't see that. So all patients with cancer should have an oral examination before the initiation of the chemotherapy. How often we have that? Unfortunately, even in my hospital, and I work in a pediatric hospital, by the time that they call us, they already start the chemotherapy. It's very rare that we get a call from an oncologist saying, we are going to start chemotherapy next week. Why you don't look? Usually these kids arrive to the emergency room. They do the diagnosis of chemotherapy pretty quick, and they want to start the therapy as soon as is possible. So these kids, it's no time to look at the patient mouth before they start that. So this is one of the statements that that is nice to say, but in real life is not like that. Okay. So these slides are your slides, are very easy to follow, and believe me, I work a fair amount of time trying to put these slides together, so what to do when you have a patient who is getting chemotherapy or I'm going to use chemotherapy because that's probably the most common. So the initial evaluation, this is the one that usually never happens. This is the one that that you are going to see the patient before they start the antibiotics. So medical antibiotic prophylaxis, obviously this patient only require antibiotic prophylaxis according to the American Heart Association only when they are going to put the catheter. So that's not related with us. We don't need to take care of that. We need to have a good dental history. We need to do a good oral and dental assessment. And then we need to prepare that patient for, explain to the patient to have why it's important to have a good oral hygiene. We need to explain to the patient that the ultrasonic brushes, they need to be careful. And we are going to explain why the mechanical toothbrushes, they need to be used very careful in patients who are getting into chemotherapy. The recommendation of the chlorhexidine rinses, you also need to be careful about that. We need to explain the patient about the diet, the fluoride, and explain to the patient that one of the potential side effects, especially from radiation therapy, is the development of trismus. These are the recommendations for patients dental or oral care before the initiation of the cancer therapy. So these are, in patients who they have, this is probably one of the most important things of patients who are getting chemotherapy or radiation therapy or hematopoietic cell transplantation. And what I'm going to refer is to the absolute neutrophil count. I don't know your skills or how deep you are in this, so if you don't mind, let me explain this in an easy way. The complete blood cell count, or CBC, complete blood count, is composed by three different things. So when we look at the CBC, or complete blood count, we look at the white blood cells, we look at the red blood cells, and we look at the platelets. So these are the three components: white blood cells, red blood cells, and platelets. I'm going to just dedicate this brief explanation to the white blood cells. So the white blood cells, as you know, are divided in different subpopulations: neutrophils, lymphocytes, eosinophils, and basophils. There are at least 4 subpopulations of white blood cells. The majority of white blood cells are neutrophils. The normal range of white blood cells in a normal CBC in a child is something in between 5,000 to 10,000. But this is the whole population of white blood cells. The subpopulation of neutrophils is about 65% of this number. I know you are now almost ready to escape this webinar, but this is the key. This is the key. Neutrophils are the most, well, I don't want to say the most important, but neutrophils are the ones who are going to protect us, the primary protection against an infection. So kids who are getting into chemotherapy, the chemotherapy is going to decrease the population of leukocytes and is going to decrease the population of neutrophils. How I will approach this as a pediatric dentist or dentist with interest in children. If the population of neutrophils, we call that the absolute neutrophil count, is more than 1,000, and let me explain this in a more easy way, almost like a Dora the Exploradora. If the white blood cell population is 10,000 and the percentage of neutrophils is 65%, that means that 6,500 out of the 10,000 leukocytes are neutrophils. 6,500. That is the absolute neutrophil count. But if you calculate that and the absolute neutrophil count is more than 1,000, we don't need to do any prophylaxis. We don't need to prescribe antibiotics. We don't need to, however, obviously, if an infection is present, we need to be very aggressive with that. But if the population of absolutely neutrophil count, or ANC, is less than 1,000, my friends, my colleagues from all over the world who are listening to this webinar, if that ANC is less than 1,000, so imagine that you work in a hospital and that kid is having chemotherapy and is having dental pain or is ready to have chemotherapy, and the population of neutrophils is less than 1,000, that patient is a high risk for infection. So we need to defer elective dental care until the ANC is higher than 1,000. If for some reason this kid who is in chemotherapy in the hospital, and this happened to me all the time, and that child requires extractions because he's in pain, that kid, and the ANC is below 1,000, ANC is below 1,000, that patient requires antibiotic prophylaxis. Not for infective endocarditis, remember that, but that child will need antibiotic prophylaxis to prevent the infection of the place that I'm going to do the extractions. I need to coordinate that with the medical team who is having or who is taking care of that patient. I will give you 2 seconds to remember that. Okay, how about the platelet count? So the platelet count is also something that we pediatric dentists work in hospitals and we take care of these patients. We need to be careful because the chemotherapy not just only is going to affect the number of neutrophils, but the chemotherapy can also affect the number of platelets. So this slide is such an important slide. Generally speaking, if the number of platelets, and remember, the normal number of platelets in a child is about 100,000, from 50,000 to 100,000. So if you have more than 75,000 and up, that patient, no additional support needed, but the pediatric dentist need to be careful when we are doing some kind of a dental treatment because that patient will have some bleeding. But this is the important part. Patients with less than 40,000 platelets, defer care, and only dental emergencies. And if the number of platelets is less than 40,000, imagine the number of platelets is just 10,000, and that child requires 2 or 3 extractions for emergency, that patient will need platelet transfusions. Now, easy to say, difficult in real life. The platelet transfusion is not my call as a pediatric dentist. Imagine if I have a patient with only 10,000 platelets, and this happened to me in my hospital. I have a patient with only 10,000 platelets, supposed to be 100,000. I have a patient with only 10,000. I need to go and pull out 2 baby teeth because they are infected. I need to tell the physician that, and the physician will need to transfuse platelets to the patient before I do the extractions. If I can defer the extraction, that's fine. That's probably better until the number of platelets goes up to the normal number. But if this is an emergency, they will need to do that. However, platelet transfusion is easy to write, difficult to do it in real life. It's a lot easier to have a red blood cell transfusion than platelet transfusion. Imagine, increase the number of platelets in 10,000, you will need about 10 donors. Imagine 10 donors for 1 bag of platelets, who is going to increase the platelet number only 10,000 more. I know you are completely dead by now. So in general, most oncology hematology protocols, hematopoietic cell transplant are divided in 2 phases. So the patient blood counts normally start to fall 5 to 7 days after the beginning of each cycle. And the platelet count in patients who are in hematopoietic cell transplantation, the blood counts stay low for about 14 to 21 days before coming back again to the normal levels. So a good pediatric dentist needs to know this. Ideally, in patients who are getting hematopoietic cell transplantation, the perfect time to do that is just before they are going to start a new cycle, just before they start the cycle. By that time, we suppose that the patient will have the blood counts, so the neutrophils and the platelets close to the normal. We need to prioritize the procedures, go to infections, extractions. So really, we need to take good care of the infections because we know that that could be the reason that the patient can develop a sepsis. How about pulse therapy or pulpotomies in patients who are into chemotherapy, hematopoietic cell transplantations, or radiations? So pulse therapy in primary teeth, although there have been no studies to date, as far as I know, that they will look how safe it is to do pulse therapy in patients in primary teeth, in patients who are receiving chemotherapy or hematopoietic cell transplantation or radiations. I prefer not to do that. I prefer not to do pulpotomies or pulpectomies, and I know some of you may disagree, but I have a reason of that. I prefer not to, as you know, if you decide to go into the pulpotomy way or pulpectomy way, there is a small chances that the tooth may not respond to the therapy the way that you want it. So you may actually are leaving a potential source of infection in the mouth. However, some of you may be in different countries. You don't have a problem doing that. But here in America, we try to be a little bit more aggressive, and we try to prefer extraction rather than doing pulse therapy. Also, a good idea to Dr. Kumar. So many ideas. I gave you one idea about oral pathology in the babies. I will give you one more idea. I have an amazing lecture of pulpotomies. I know, it sounds crazy. You guys are really experts, and this guy is telling you that he wants to give a lecture. No, seriously, we need to go over the lecture on oral pathology in the baby. That's a nice lecture. And also, I have a lecture of more advanced imaging in malignant and benign radiographic lesion. That could be also a lecture. How about root canal? So symptomatic non-viral permanent teeth should receive root canal at least 1 week before the initiation of the cancer therapy. That's easy to say. In real life, that doesn't happen. It's like the patient is going to start the chemotherapy in a week, so I can go ahead and do the root canal. But what happened is when they call us, it's too late. And then we don't have the time to do that. If root canal is not possible and you cannot do the root canal, which is usually what happens in real life, then we prefer to do the extraction. And obviously, we need to put the patient in antibiotic therapy. I prefer penicillin at least for 1 week. How about ortho appliances? This is common for us. And remember, if someday in your life you want to spend some time with us here at Riley Children's Hospital, I can facilitate that. I mentioned that last year I have a dentist from Pakistan, and I have dentists from different places of the world that they spend 1 week with us here, and I can help you with letters of invitations in case that you need to go on and have a visa. I can help with that, but if you really want to come here to us and see these things in real life, not just only in a webinar, I will invite you to do that. It's an honor to have you coming and asking to come to see us. Obviously, during these coronavirus times, it's more challenged to do that. But as soon as we have the vaccination and we move away from this coronavirus, please think about it. Dr. Kumar came to visit us here in Indiana, and he stayed with us, and we have a couple of Dr. Kumar was with us at least for a week, if no more than that, and we have seminars in sedation, nitrous oxide, and we will take good care of you if you want to come here and observe and have some time with us. So
very good.
What I was mentioning is about ortho appliances. Yes.
I want to say you are a very good host, actually.
I know. I love to, and I love to have colleagues from different places of the world coming here. So if you have a child who is getting into chemotherapy, and this happened to us here at Riley, and he has some orthodontic appliance and a space maintainer, and they are not very well fitting, the recommendation is to take it out. If the patient is not a good hygiene, and you see that the chemotherapy protocol, especially for chemotherapy or hematopoietic cell transplantations, is going to cause mucositis, we prefer to remove any appliance who is in the mouth. We prefer to do that. If the patient is in a good hygiene, which sometimes, as you can imagine, hygiene is not the first priority. There are 20 more priorities. but maybe in some unique cases, you can leave the appliances in the mouth. Periodontal treatment, partially erupted molars can become a source of infection because pericoronitis. So the overlying gingival tissue should be excised, and the dentists believe this is a potential for infections. Extractions, there are not clear recommendation for the use of prophylaxis antibiotic for extractions unless the ANC is below 1,000. If there is a documented infection associated with the tooth, antibiotic prophylaxis, antibiotics should be prescribed for about 1 week. If the patient is getting radiation therapy, remember, we need to minimize the risk of osteonecrosis associated with the radiation therapy. Primary teeth, they need to be allowed to exfoliate naturally. If extraction is necessary, again, ideal time is 7 to 10 days before the cancer therapy starts. How about preventive strategies? Thrombocytopenia should not be the only reason to decide the patient is not going to brush or not. And this is probably my take-home message here. During the time that the patient is in chemotherapy, the patient needs to be very gentle with the brushing, because some of these patients going through thrombocytopenia, as I explained before, and if you brush using mechanical toothbrushes and very strong, and you really have like a battle in your mouth, that kid will have some significant bleeding. So the idea is to be very gentle in the brushing, because a strong brushing or mechanical toothbrushes, they may cause bleeding. Flossing is something that sometimes there is a controversy about flossing during the time of chemotherapy. If the patient was flossing before and the patient has the skills for flossing without causing major trauma of the tissues, I believe it's reasonable to continue flossing during the treatment, during the chemotherapy. I don't see any reason why to stop that. However, if the patient is having, never floss, and I don't think it's the time to try to explain the patient how to floss. And I would prefer to be away from flossing. Toothpicks and water irrigation devices should not be used when the patient is during the pancytopenic, which means the neutrophil count pretty low, to avoid tissue trauma. How about the management of the oral condition related with cancer therapy? Mucositis. Mucositis is terrible. It's terrible. And honestly, when I see kids with mucositis, there is a whole is the most excruciating pain, and is horrible. If anybody still listening my webinar and you want to have the protocol, the mucositis protocol that we have here at my hospital, I can email that to you, which is a very specific protocol that we have. And I don't want to share it here because I don't know, this is not the same in all the countries in the world. But if you want to know how we deal with mucositis here at Riley, I can tell you how we do that. We actually don't recommend the use of chlorhexidine during the time that the patient is having a mucositis. We don't prescribe analgesics. We prefer the use of the patient-controlled analgesia with narcotics. It's probably the only way that helps. So it's not any point to prescribe Tylenol, to prescribe ibuprofen. They are not going to work. You need to use the patient-controlled analgesia. That's what we use in our hospital, which is basically narcotics. I don't, and that's the reason that if you want to have the protocol of mucositis, I will send you what we send here. There is a conflict evidence about the use of the magic mouthwash. The magic mouthwash, depending on the country that you are, the recipe is different. In some countries, the magic mouthwash is a combination of an antihistaminic, also the combination of anti-reflux medication, and the combination, and also lidocaine. So in some countries, the magic mouthwash is different. There is mixing evidence about the benefit of using magic mouthwash in kids who are having mucositis secondary to chemotherapy. Also, a good source for that is our textbook, Dentistry for the Child and Adolescent. We have a whole chapter about mucositis. And again, I can share the particular protocol that we have here. Topical anesthetics like a topical lidocaine, we also don't like to use a lot of that because there are some side effects associated with the use of topical lidocaine, and also it's difficult to take it to the mouth. We recommended the non-alcohol mouthwashes, and that's usually what we do. And again, if you want to have the whole protocol, I will send it to you. How about the management of the oral conditions related with the cancer therapy? Well, we talk about mucositis. The other one is the oral mucosal infections. Interesting, nystatin prophylaxis is not effective for the prevention of treatment of fungal infections in the mouth, so we don't prescribe nystatin. We prefer to use IV antifungals if the patient develop a fungal infection. One of the most terrible things, and it's just amazing the amount of pain, is the dental sensitivity. Yes, for some reason, during the time of the patient, when the patient is in chemotherapy, especially patients who are in alkaloid chemotherapeutic agents, which they are widely used in the whole world, vincristine and vinblastine, the patient will have dental sensitivity in a way that the patient will be having a excruciating pain. I remember, like today, when I was in medical school, when I was in my third year medical school, I was in the internal medicine rotation, and we have a child in the floor, in the guard. We have a child who was having chemotherapy for acute lymphocytic leukemia, and that patient, I remember that night, was screaming the whole night, and we couldn't really find a way to help him having sensitivity because the chemotherapy agents who actually were used for him, especially the mandibular molars, it was absolutely heartbroken. Unfortunately, he's listening this lecture, or he's listening me from heaven because he passed away a few days after that. But I remember that pain was excruciating pain. And the reason is because some chemotherapeutic agents are associated with that. The good news is the pain is usually transitory, but again, during the time that the patient is having the pain, is heartbroken. How about, well, we talk about the floss daily. The patient is already doing that. That's fine. The patient should be seen at least every 6 months, like any other patient. This is for patients who are in hematopoietic cell transplantation, HCT. So this is specifically for HCT. Patients who experience graft versus host disease, remember, they supposed to be seen in the office a little bit more shorter intervals. And how about the ortho treatment? May start or resume after completion of all therapy and after at least 2 years of disease-free. So we always try to advise the patients that wait for the ortho treatment until the patient is disease-free. Patients who are in hematopoietic cell transplantation, they go through 2 different phases. The phase 1 is the pre-transplantation phase. In hematopoietic cell transplant, the patient received all the chemotherapy and radiation in just few days before the transplant. In hematopoietic cell transplantation will be a prolonged immunosuppression following the transplant. So generally speaking, in patients who are having hematopoietic cell transplantation, elective dentistry must be postponed until a full immunological recovery. So in these patients, the elective treatment supposed to be postponed at least for 9 to 12 months after the hematopoietic cell transplantation is done. These are the, this is just a slide to show you the most common complications in patients with hematopoietic cell transplantation. And probably the main one is the neutropenic phase. So when the ANC is below 1,000, that's when we can start to see complications in the oral cavity. And the complications are related with opportunistic infections and the susceptibility for infections. Okay, I'm going to stop here. This is the longest webinar that I have so far. This slide will have about 20 more slides, which is patients with bleeding disorders, patients with neurological disorders, and patients with, well, that's neurological disorders and bleeding disorders. So the whole slide is, the whole PowerPoint is yours. I think so, Dr. Kumar, we are going to have a break about 2 weeks. I really don't know when we are coming back. This is going to break my heart because I really like to do this. And so I think so, people, you need to be looking at the association website, correct, Kumar? And then we will decide when we are going to have the next webinar, correct? Okay. So we are done from today. I hope that you enjoy, and we will get back at some point. Dr. Kumar, are you there? Dr. Kumar? Okay. Well, it seems like I lost Dr. Kumar. I hope that at least somebody was still listening to this seminar. From everybody, have a wonderful, I hope that you learned something. Please send me an email telling me where are you coming from. I want to hear what's your country and your city, and have a wonderful, wonderful weekend. And please be safe, stay at home, and thank you so much for coming to this seminar. This is Dr. Yepes from Indiana University, and I hope that I can see you face to face one day. God bless you and have a good day.